I have the pleasure of introducing someone who's incredibly special to me and an incredible friend of OCOM. So Dr. DiPietro is the chair of the Florida Board of Osteopathic Medicine. She is a triple board certified cardiologist. She is a concierge physician to the Stars down in Fort Lauderdale, Florida. She is, and I was telling my daughter this a couple of nights ago that, you know, I've had the pleasure of meeting a lot of great people in my life, and you know, there's a few very, very incredible, special people that you know, I met, and Dr. DiPietro is one of them. She was one of my medical students, one of my first medical students, and also one of my residents at the residency program at Palmetto General Hospital. She also became one of the early fellows of the cardiology fellowship that we started at Palmetto General Hospital too, and just a close dear friend of OCOM. So without further ado, please join me in welcoming Dr. Tiffany DiPietro.
Okay. So probably we'll have some questions towards the end. If you could just hold them till the end, maybe just jot them down or mentally note them. It just kind of helps the flow a little bit. And I might end up answering your question anyways later in the lecture. So just a little bit more of a background. So I practice concierge internal medicine. So I still actively practice primary care. And then I have a cardiology practice as well. That's what I was trained in. And the majority of my cardiology practice is preventive cardiology. So I'm not an interventionalist. I might refer people for stents and valves, but I don't do them. My goal is to prevent someone from ever having to need a stent or ever having to need open heart surgery. So that's basically going to be the focus of this presentation, is how we can pick up on disease early and help people live very long, healthy lives. I like to focus, I don't know if any of you have heard it, we're using the word health span now. So not just lifespan, but health span, and how not only to help people live longer, but help them live healthier and vibrant as we age. My favorite quote is in my office on the wall: an ounce of prevention is worth a pound of cure. So if we can just prevent disease, we really need half of the things that we're becoming very technologically savvy about fixing now. All right, so first years are here, right? Yeah, fair. Okay, so you guys have learned all this stuff already, right? So traditional risk factors, still true. The older we get, the more likely we are to have heart disease. If we smoke, we're gonna have more heart disease. Regular lipid panels, high LDL, low HDL. Family history. I cannot stress how important this is. People blow through family history. It's probably, arguably, more important than anything else on the board. If someone's father dropped dead at 45 of a heart attack, that's the biggest risk factor you're ever going to have. Diabetes, just for everything, and obesity. Okay, so new risk factors. Something that we draw in my office every single day. So even in my regular patients, not my cardiology patients, every single patient gets a high sensitivity CRP every year. Every patient gets something called an LPPLA2, which I'm going to go into. Every single patient gets an advanced lipid panel. So it's not just the LDL, it's the LDL that's fractionated, it's the LDL particle number, it's the lipoprotein A, the apolipoprotein B. They get full advanced lipid panels. Coronary artery calcium scores and coronary CT angiograms, which we're going to go into a lot of depth on today. And then the importance of mental health and stress. So I'm going to veer off for a second. I was just talking, excuse me, to a colleague the other day, and there's two kind of famous doctors right now that are kind of getting in this 60 minutes battle. Literally, like, they did an interview with one, and then they interviewed the other one, and they're like battling it out, the two of them. And one of them is Dr. Peter Attia, and the other one, I can't remember his last name, but his first name is Ezekiel. And they're talking about health span, lifespan, what you need to do. And Dr. Attia says it's all about exercise, and it's all about getting the lipids down. And Dr. Ezekiel says, no, it's all about having a social life. And he got mad at Dr. Attia because Dr. Attia didn't talk about social life, and it's important to have friends, and it's important to have goals. And I would argue to say that it's all very important, but at the end of the day, if you're stressed out and you don't know how to handle your stress, that's going to be your biggest risk factor. Because the stress is going to cause the inflammation, which is going to cause all the downstream problems. So everything's very important, but at the end of the day, because we all have stress, but if you don't learn how to manage that stress appropriately, that is ultimately what's going to kill you. So who actually has heart attacks? So when I ask my patients the next question, everyone says the same thing. So if I have two patients, and I have patient A, that has an 80% blockage that's calcified, and I have patient B that has a 30% non-calcified cholesterol plaque in the same artery at the same location, who's the higher risk of having a massive coronary event? Correct. The 30%. You ask any cardiologist and they will tell you, I will take that 80% calcified plaque all day long over the 30%, because those are like concrete. They're not going to break. They don't rupture. It's the soft lipid plaques that rupture. Now, the calcified plaque started that way, okay, but the point of the statins is to calcify it. That's what we want to do. So we're hoping to regress the plaque if it's soft, which we can, maybe, it's there, it can happen, but we want to stabilize it. That's the calcium, okay? So that's another argument I hear all the time, like, why do we want calcification in the arteries? No, I don't want anything in the arteries, but if I had to pick, I want that artery to be I want the plaque to be calcified. I do not want a soft plaque. That's a major problem. So, less than 50% occlusions cause the majority of myocardial infarctions in this country, okay? What does that mean? That means they had no symptoms, 0 symptoms before something happened. So the guidelines, that I'm gonna veer a little bit, but the guidelines that support symptoms prior to treatment makes no sense. Because most of the time, a patient has no symptoms before they have a cardiac event. So the statistic out of Cleveland Clinic, which is staggering, is the first symptom, someone's first symptom, which percentage of patients, the first symptom ever is just death? 50%. 50. So if we're waiting on people to have a problem or a symptom before we treat them, we're not treating 50% of people because they're going to die. Okay, so how do we find those people before that event happens? And that's the goal for today. So I don't want to get too scientific, but this is the difference. We have our vulnerable plaques and our stable plaques. So our vulnerable plaques are the ones that have a very thin fibrous cap that are much more vulnerable to rupturing, and our stable plaques have our thick fibrous cap that have already started to calcify that are much less vulnerable to rupturing. Okay. First years, I think you're probably learning more anatomy and physiology. Have we heard of coronary artery calcium scores? Okay. Have you heard of coronary CT angiograms? Really? That's nice. Okay. Most people haven't. All right. So the primary cares of the world, whom I love because they're my colleagues, have this very odd obsession with coronary artery calcium scores. And it drives me bonkers. Because if you're a young person and you have a coronary artery calcium score, arguably less than the age of 50, most people, it's probably going to be 0 because the calcium has not had time to form. And so what happens with these patients is, I'll give you an example because I see them every day. It is a 48-year-old guy with an LDL of 160 that should be 100. I don't want to take statins. I heard they cause dementia and diabetes. I don't want to put that in my body. ChatGPT told me they were awful for me, right? So they go to their primary care doctor, and their primary care doctor orders a coronary artery calcium score, and it comes back as 0. Have you convinced that guy to take his statin now? No, right? All you did was the worst thing you could have done for that patient, because now they have more in their armamentarium to say, see, I'm fine. I don't need to take anything. When more likely than not, there's something there that just hasn't calcified yet, and you can't see it on that calcium score, okay? If we take the same test and we add IV contrast to it and just slow down the test a little bit, we get a coronary CT angiogram, which is essentially like looking at a cardiac catheterization, but it's a CAT scan. And the test itself takes about 1.5 minutes, and you will know everything about that person's heart. So the younger we are, the more in depth we have to look. Okay, if you have a 70-year-old with a coronary artery calcium score of 0, I'm okay with that. But a 40-year-old, I'm not okay with. Now, the flip side to that is if you have a 40-year-old with a high calcium score, you got a problem. Okay, but we should never, ever, 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 ever be ordering calcium scores on young people. Here's the data. So there was a big study done in the Danish study. There's about 24,000 patients, okay? And I'm going to read this slide because it's very important. Among patients with obstructive coronary artery disease on coronary CTA, the prevalence of a zero coronary artery calcium score fell with increasing age. So, right? So the older we are, the more likely you are to have some coronary calcification on a coronary artery calcium score. However, prevalence of 0 calcium score with obstructive coronary disease on CCTA, 58% of people younger than the age of 40, they would have had a 0 calcium score. 34% of patients aged 40 to 49, and 18 were 50 to 59. So you see, the older you get, the more likely you can rely on a calcium score. But the younger you are, you cannot rely on it. And all you're doing is setting your patient up for failure because they're just not going to take their meds because they're going to think everything's okay. This is just another study out of circulation. So 30,000 patients, big study, 30,000 patients 50 to 69 without any known coronary disease. The reason I love this study is actually mostly women, which never happens in cardiology research. So almost 51% women. Any coronary disease was found in 42.1% of people. Do you think those 42% of people thought they had any coronary disease? No. Okay. This is how we drive treatment. This is how we get people to be compliant. This is how we get them to take their medicines. So what can we do? So we have the picture, right? And then what do we do with it? So is there a pointer? Yeah. Maybe not. Okay, that's okay. So if you look on the top left, the traditional, you have your calcium score, again, just sees calcium. And I have more pictures, I have case studies. And then the coronary CT angiogram where it says stenosis, you can actually see the blockage. The white is actually the blood flow through the artery, okay? So what else do we have now? My favorite is kind of down here, the functional. So in the cath lab, if the interventional cardiologist has a question on whether or not the blockage is significant, they do something called FFR, which stands for fractional flow reserve. And what it does, it's a little catheter that goes inside of the artery and it measures the pressure before and after the stenosis. And if there's a more than 20% pressure drop, it's considered hemodynamically significant and it should be opened, okay? Some geniuses out in California figured out how to do this on CAT scans. So they can measure the velocity of the contrast going through that vessel before and after the blockage. And then the calculation's 4V squared. They can measure the pressure and they can see exactly what the FFR would be without the patient ever having to leave their home once the study is done. So now we basically can do a diagnostic cardiac catheterization on a CAT scan, which has completely changed the face of cardiology in this country. Every single one of my patients that go to the cath lab because I have a positive FFR. I already know what I'm going to open before they even get to the cath lab. Then we have artificial intelligence, which we're going to talk a little bit about as well, which also includes the plaque assessment to show you how thick that fibrous cap is, how much fat there is, and how much risk that artery is for rupturing. So this is an example of CT-FFR. So anything that's under 0.8 is considered hemodynamically significant. So this was the problem. This person ended up going for open heart surgery. But let me tell you how much it helps, because I told him that before he even left my office. I said, more likely than not, you're going to need open heart surgery. And I could tell him that by looking at a CAT scan, which we were not able to do 10 years ago. So we still have to do a cardiac catheterization. That's just guideline management to confirm. But I, with 90% probability, can tell them exactly what's going to happen in the cath lab now. So this is exactly what we get back on the patient. It tells us exactly where the blockages are and what we have to be worried about. I don't know why those numbers are up there. I think someone called me and I needed to write down a phone number and I had this slide open and so I just wrote the phone number there. Actually, I know that's what happened. Google it and tell me who I was talking to. Okay. So this is through a company called HeartFlow. It's one of the companies I'm now a speaker for. And HeartFlow does FFR, heart flow, the flow through the vessel. But their new product, which is really, really cool, is plaque composition. So it takes a coronary CT angiogram, it shows you the FFR readings, but it also pulls each vessel down in a straight form and tells you what percent is calcified, what percent is non-calcified, and what percent is your high-risk, low-attenuation plaques. All from one test, which is unbelievable, okay? I will tell you as a doctor that likes to prescribe medicines for cholesterol, this changes people's minds. This will get someone to take medicines. This will get someone to stop smoking. This will get someone to exercise. This will get someone on the OOO. It will get someone to do anything they need to do to make this better, okay? So again, coronary artery calcium is more helpful in older populations. It's a risk factor stratification. It's not for diagnosis of obstructive coronary disease. You could have a very high calcium score, it could all be on the outside of the vessel, and it's not obstructing the flow at all, okay? So it's not the best tool that we have. It's an okay tool. It's a cheap tool. It's only about $100, but it's not the best tool. And again, coronary CTA should be considered in younger patients. I order probably 25 coronary CTAs a week. I don't even order stress tests anymore. Everybody gets a coronary CTA because stress tests, nuclear stress tests are more radiation, a lot more radiation. So this is a little bit of radiation for all of the information you could want. It's a win-win. At our institution, it's about $500 out of pocket. It's really not a lot of money for the information that you're getting. And we see about 2/3 of the lung volume. So they're paying for a coronary study and they end up getting a pulmonary study at the same time. Okay, these are real cases. These are from my office. So these aren't made up. So patient DJ, 42 years old, this is a male, with unrelenting fatigue. That was the symptom. It wasn't chest pain. It wasn't shortness of breath. I'm tired. I'm tired. I'm tired. I'm tired. I'm tired. I'm tired. Happens all the time. Thyroid function's normal. Hemoglobin's normal. There was really no reason as to why this patient should just be fatigued, other than the fact that they're 42 and probably have 3 kids and work a lot. Coronary artery calcium score was done with the primary care doctor. It was 0. Again, as expected. Okay. The labs revealed a bad cholesterol, LDL of 131. Okay, so let me talk about that again. It's also a thing with primary care. Like, oh, it's not that bad. It's 31% higher than what it should be. That's bad. Okay? 131 it should be 100 or under without coronary disease. So it's bad. It's the 30% high. I mean, if you got a bad grade, you'd want it to be 30% higher, right? 30% it's a big chunk in medicine. So that's high. No high blood pressure, non-smoker. So me, being the preventive cardiologist, I order a cardiac CTA, which she pushed back. The patient pushed back and I said, listen, something's not right. Something doesn't make sense. I see your lifestyle, everything, you're sleeping. We went through everything. Ruptured plaque in the mid-LAD causing critical obstruction. And appears at least subtotally occluded. Large caliber first obtuse marginal non-calcified plaque subtotally occluded. She had open heart surgery. Guess how she feels? Fantastic now. She wasn't getting enough blood flow. She was tired because literally 2 of her arteries could not adequately pump her heart. And going back, let's see. No plaques in the left main. Non-calcified, ruptured non-calcified, non-calcified. Everything's non-calcified. That's why her coronary CTA was 0. So had we not ordered this, probably just would have kept being fatigued and ultimately would have dropped dead. Okay, this is my favorite story. So I bring him up in every lecture because he's fun. So kind of this high-strung guy comes to see me, first visit, and he's like, Doc, I need a calcium score. And I said, okay, let's just stop there. What's going on? And he says, and I talk to my patients, so I talk to you guys. And he says, well, I play ice hockey really aggressively, and my friend, he just dropped dead on the ice. He just died, just dead. Like we did CPR, he didn't wake up, and he died on the ice. And I said, well, did he have any symptoms? He's like, I mean, I don't know. He was my best friend, but he never told me he had symptoms, but maybe he did. I don't know. He goes, I want a calcium score. I want to make sure everything's okay. I said, so I told him I tell all my patients the same thing. What's the difference between a calcium score and a CTA and what you're looking for and what you're not looking for? And I said, listen, the only way I can unequivocally tell you if you have no blockages and no problems is to get this coronary CTA. And he likes to read, and he's kind of an odd guy, but very smart. And he's like, I read the guidelines. The guidelines don't say that because I don't have any symptoms, and I want a calcium score. I said, again, you're coming to me asking me if you have any coronary disease. There's only two ways I can answer that. A coronary CTA or cardiac catheterization. I'm never going to be the doctor that has you do a stress test and says, you've got the heart of a 30-year-old. I don't do that. I don't know if you've got the heart of a 30-year-old. I don't have x-ray vision. So finally, after berating him for an hour, he agrees. 99% proximal LAD. This guy, I don't know how to say this nicely. I actually told him this, so I'm just going to say it. I said, you could fart the wrong way and you would die. That will kill you. That is 30,000 feet in the air and that ruptures, you're dead. If you're surfing or snowboarding, you're dead. I don't know how he had no symptoms. I do not know how. So then he argues with me on whether he needs it opened. Oh, but the guidelines say I don't have symptoms. I'm like, yeah, you're going to die. There's no guideline on death. You're going to die. It needs to be open. So funny story is fast forward about 3 years from when this happened, new guidelines came out and say, oh, if you see something asymptomatic, but it's high risk on a CTA, you should probably open it prophylactically. Yeah, no, duh. So I was proud of myself. I said, I told you that was going to happen. So goes and gets a stent, gets it opened. Everything was fine. And the interventional cardiologist calls me. Funny enough, he ends up being his daughter's in my son's class now, and he has a crush on her. It's so funny. And Alex Llanos. And he calls me and he goes, Tiffany, I've never in my life seen anything like this. I go, what do you mean? He goes, I actually could not believe this. I got out the intravascular ultrasound machine, the IVUS machine. So it's a way of doing ultrasound of the inside of an artery. He's like, I was dying to know how thick this fibrous capra was. It was like 5 microns. This thing, there's no way he would have probably lived another week. And he's like, how'd you know? I go, you don't know unless you look. So that's my new rule in my office. You don't know unless you look. So $500 saved his life. And that was, how much calcium's in that? 0. His calcium score would have been 0. There was not a speck of calcium anywhere in any of those arteries. And that was the only artery he had a problem in. Non-smoker, no family history. All he had was high cholesterol. Prevention. Take home. I'm missing something. Oh, there we go. Okay. 2021 European Society of Cardiology Prevention Guidelines. Most cardiologists usually follow European guidelines because the American guidelines will be those in 5 years. So they're usually ahead of us by a solid 3 to 5 years. So in 2021, the major risk factors are the same: the smoking, the age, the family history. Psychosocial stressors and air pollution were now recognized as being associated with adverse cardiac events. Stress management was reiterated multiple times in the guidelines. Chronic kidney disease is now an independent risk factor. Now we have this lower is better, okay? The lower the LDL, the better. So I'll give you another story because he wouldn't mind. So my program director for cardiology is my patient now because his wife doesn't want him taking care of himself. So he comes to me and I look at his med list and I said, Raul, you're on like everything. He's like, yeah, I don't want 1 LDL. I don't want 1. So I look at, and he's on like, I get his labs back, his LDL, less than 10, like completely undetectable. He's like, no, I don't want any of it. It's bad. Because cardiologists know that you don't need, I'm going to say this, you do not need a high LDL for brain function. I don't know what this is on the internet, but toddlers and infants, when they're growing and utilizing more of their brain than anyone ever will, because they're learning and growing, do not have LDLs of 160. They maybe have an LDL of 120. So you don't need one of 120 because you're not learning as much as the infant is. So that theory is kind of out the window. So his LDL is less than 10. I don't know if I need less than 10, but we say usually 50. That's what most preventive cardiologists say. We want your LDL at 50. Not easy to get there sometimes. I will also tell you that a purist knows it's not generally diet. If someone's eating a whole bunch of really bad foods all the time, yeah, but generally it's not diet. You can change someone's diet and you're not going to see a huge drastic reduction in LDL generally. You'll see a good change, but it's usually not drastic. And there's now a big focus on diabetes medicines like the SGLT2s and the GLP-1s, which I prescribe every single day. I think they're miracle drugs, and I think probably 80% of the population should be on them. Oh, okay. I wasn't looking. Sorry. Okay. So CRP versus high sensitivity CRP, another test I draw every single year, sometimes more than once a year. Basically, the high sensitivity CRP is a de facto measurement of coronary atherosclerosis or coronary inflammation. Less than 1 is considered very good. 1 to 3 is a mild elevation, 3 to 10, and then greater than 10, there's probably something else going on if it's greater than 10, like maybe they're sick or they have the flu or they have cancer, I don't know. You have to be careful with this. Different things can also just elevate the hs-CRP, but it's nothing bad. So like birth control, for instance, will elevate the high sensitivity CRP. So you have to be careful when you draw it, that you know how to interpret what you're looking at. But when I see a patient with a low hs-CRP, I get happy because I know that probably everything inside their body is like copacetic. And the way I explain it to their patient is like your body likes itself. There's no like internal derangement going on. If someone has a rheumatologic condition, it's probably going to be high. So you just have to be careful who you draw it in, but it's meant to be kind of like a risk factor stratification of who you need to be worried about. Okay, these are just the ACC/AHA primary prevention guidelines for 2019. The reason I put them up here is they do have in selected individuals an hs-CRP of greater than 2 is considered significant, or an ApoB greater than 130, which I think I have ApoB on another slide. But it's just talking about how high sensitivity CRP should be used as a risk factor target now. All right, so if we look at the quartile of high sensitivity CRPs and then the risk of having a heart attack, the higher the CRP, the higher the risk of someone having a heart attack. It's pretty straightforward. Okay, and again, what's the big problem? Inflammation, which is why stress is a problem. Okay, so at the end of the day, if you have a lot of inflammation, again, as thus measured by the high sensitivity CRP, you got a problem. So inflammation is like getting the inflammation down is the goal, which is also sort of something that statins do as well. That's why we like statins as cardiologists. They decrease inflammation also. Weight loss. All right, it's not healthy to be fat. It's not. So if you like the way you look and you're proud of it, that's cool, but it's not healthy. It's never healthy to be overweight, ever. That's why there's such a bell curve of healthy weight, okay? There's here and here. If I look at the bell curve of where I fall to be healthy, it's like an extra 35, 40 pounds on top of what I am now. There's a big bell curve distribution of healthy weight. So when you fall out of a BMI, unless you are literally a jacked bodybuilder, more likely than not, you're obese, okay? That is going to cause inflammation. That is going to cause you to die. So what I tell my patients, again, sometimes I'm a little harsh, but it gets to the point. When I sit down and we talk about weight, it's not my weight, it's not my weight. I say to them, when is the last time you saw a fat 80-year-old? Not very often. And then I go, why? And they go, because they're dead. Okay? That's a problem. So weight is very, very, very important. And a good preventive cardiologist will focus on weight arguably before they focus on anything else. So we took this study, 83 women with a mean BMI of 33.8, which is obese, placed on a very low-fat diet for 12 weeks. Their CRP reduced by 26%. What's that inflammatory marker? Average weight loss is 7.9 kilos. The CRP was associated with a change in triglycerides, but nothing else. It was a huge triglyceride change. But more importantly, the CRP reduction was huge. And as we saw in the last slide, the less CRP, the less likely you are to die of a heart attack. The Jupiter trial, which was out, oh my gosh, I was probably an internship right when Jupiter came out. Patients with low to normal LDL who were considered increased cardiovascular risk due to elevated CRP who did not require statin therapy based upon the current guidelines had a 44% reduction in primary endpoint for rosuvastatin versus placebo, just based upon their high sensitivity CRP, and a 20% reduction in mortality. So again, the statins will help the inflammation, separate from the cholesterol. And now there's newer evidence for initiation and colchicine. So it's still a little bit of a gray zone in cardiology, but if we have a patient that's been maximized on their statins, they have coronary disease, they've been maximized on their statins, their LDLs are good, they're feeling good, and they still have a elevated high sensitivity CRP of greater than 2, now there's a treatment guideline to initiate colchicine, which is an anti-inflammatory generally using gout daily of 0.5 milligrams, which is funny because the gout treatment is 0.6, and that's super cheap. So what did the pharmaceutical companies do? Ours is 0.5. So, and that's super expensive. So it's kind of frustrating, but I have seen the patients that I've put on colchicine daily, their hsCRPs come down precipitously on the colchicine daily. This was just a graph of the Jupiter trial showing that the reduction in the high sensitivity CRP and cardiovascular death with 20 milligrams of rosuvastatin, which is my favorite statin. LPPLA2 test, we call it a plaque test. Stands for lipoprotein-associated phospholipase A2. As you can see, it's an enzyme that breaks down oxidized low-density lipoprotein in the vascular wall. So if you have elevated levels of that, then we think that there's been vascular damage. So we kind of, again, once I have a coronary CTA, it's kind of like, who cares? But it is a laboratory way of kind of de facto looking if someone has an issue in their arterial walls. All right, if you don't know about this, this is probably the second most important slide. Lipoprotein A. The way I describe it to my patients, it's a very sticky, very problem-causing cholesterol particle that you can do absolutely nothing about. So it's an issue. You cannot diet your way out of it. You cannot exercise your way out of it. Whatever you have is what you were born with, and you're stuck with it. There are some medications, one class of medications called PCSK9 inhibitors, which are coming up, that will decrease this about 30%. But that's not what they're indicated for by the FDA, so you'll never get it approved for that. But these little suckers are problem-causing. And the problem, again, is it's genetic. You can't do anything about it. So these patients that have elevated lipoprotein(a), you really have to modify their risk as low as you can get it. So their LDLs, because you can't control this, you need to control everything else. Now, again, just because someone has a high lipoprotein(a) does not mean they're going to get coronary disease, but the likelihood of them having coronary disease earlier in life is much higher. So I have a patient that has a lipoprotein(a) of like, normal is less than 75, hers is like 350. It's one of the highest I've ever seen. We did a coronary CT and it was clean. So lucky her, but that's usually not the case. And then there's people like me, genetically, I don't have it. Mine's less than 10, it's completely undetectable on my lipid panel. So it's a very good way of kind of gauging. And then most of the time, when you see a patient that like, everyone in their family line has had coronary disease, and you check their lipoproteinase, they're high. It's a genetic thing. They're high. There's phase 3 trials going on right now with like 2 competing pharmaceutical companies. I was at the American Society of Preventive Cardiology conference this year, and they should be out maybe last quarter 2026, first quarter 2027, dedicated for lipoprotein(a), drops the levels 90%. So that's going to be huge in the world of preventive cardiology. How they're going to be approved, I don't know who they're going to be approved for, but I need to go back and look at the drug companies so I can invest. All right, again, association of, we call this LP little a. LP little a with atherosclerotic plaque progression. 191 patients, a median LPA of 100, which is just over what's considered norm. Norm is 75 or under. No difference in coronary artery disease or plaque burden at baseline. And those patients with this elevated lipoprotein(a) showed accelerated progression of low attenuation plaque. Okay, so it's just, it kind of stinks because, again, there's nothing you can do about it, but you really have to modify the risks, the other risks, as much as you can. And this is a one-time test. There's no point in checking it more than once because it's going to be about the same every time you check it, unless you're on one of these new treatments that are coming out. I have patients that like every 3 months are checking. I'm like, what are you doing? It's not going to change. All right. So the lipoprotein(a) test is sort of expensive. Can't tell you exactly how much, but it's not a super cheap test to have drawn. Apolipoprotein B is a de facto way of measuring lipoprotein(a) that's a lot cheaper. So apolipoprotein B is, there's one for every bad type of cholesterol particle. So there's one ApoB for every LDL, there's one ApoB for every IDL, VLDL, and lipoprotein(a). So if you just measure the apolipoprotein B, you can kind of get an idea what everything else is. So if someone has an LDL, for instance, an LDL-C that's low, and you get an ApoB and it's really high, it's probably their lipoprotein(a) that's high, because it's like discordant between the two. Okay, so a purist will say to have your lowest risk, your apolipoprotein B should be like less than 50, And if you think about that accounting for every type of cholesterol particle, that's pretty low. But it's a de facto way of measuring all types of bad cholesterol without doing a huge advanced lipid panel that can be a few $100s. ADMA, sort of, kind of, I don't check it all the time. It's a competitive inhibitor of nitric oxide synthase, reducing nitric oxide production and promoting endothelial dysfunction. So it decreases with exercise. So the more aerobic activity, the better endothelial function. I don't really check it a lot, but it's kind of cool when I do check it. But I just don't feel like it drives any decision making for me. And I tend not to check things unless it really changes my decision making with treatment. Okay, this is right out of my EMR. So this is June of 2021, a 44-year-old woman without any medical problems at all, no family history of heart disease. She doesn't smoke. She's got a good BMI. And she came in and said, I have a history of a high lipoprotein A. I guess it was already checked. So total cholesterol was 230. HDL was great at 74. Triglycerides were great at 80. And her LDL, again, high at 139. So this is her breakdown. So another thing we like to look at as preventive cardiologists is the particle number. And I'm going to talk about that in a second. Arguably, particle number is more important than the LDL-C. So she had a very elevated particle number. It's actually how many LDL particles she has. And I will tell you also, I've never seen one patient, myself included, with a pristine lipid panel. I've never seen a patient with not one orange dot next to anything. Almost everybody has something that's a little off on their lipid panel. I have an LDL of 44 on no medicine, and I still have like a dot on something. I don't even know how you do that. Her ApoB, 110. Lipoprotein A, 307. So super high lipoprotein A. But look, her high sensitivity CRP was only 0.6. So she might have something going on inside of her, but maybe it hasn't like ruptured yet or become obstructive or cause a problem. So and LPPLA2 activity 98. Remember, that's supposed to be a measurement of endothelial like dysfunction, like something's going on inside of the artery. So she goes, no, I want a cardiac CTA. So she had a lot of little stuff, okay? So the left main had a little non-calcified plaque, left anterior descending was clean, circumflex was clean, and the right coronary non-calcified plaque, 30 to 40%. So again, it kind of makes sense why the HSCRP and the plaque tests were normal, because it was some stuff and it was on the arterial wall, but it really hasn't caused any dysfunction of anything yet. So what would we do on her? Anyone? Bueller? Okay, so he said PCSK9. If I could get it approved for that, I would love that. The problem with PCSK9 inhibitors is they're very, very, very expensive. Yes. So what we normally do, and what I try and convince my patients of, despite what the internet says, just try the statin. That's what I say, just try it. Because whatever side effects you have from it, it will stop when you stop the medicine, guaranteed. I've never had someone have long-term ramifications of their statin. So I don't remember what I put in the slide, but what I would do is initiate rosuvastatin, probably at 20 milligrams, which is considered a high moderate dose, and recheck everything in like 6 weeks. And look at the liver function, make sure her liver's not all messed up, make sure she's not having side effects, and what goal LDL are we shooting for? Less than 70, because she has coronary disease. I want 50, but we're shooting for less than 70. Okay, Europe says 50. So if it's 64, I'm not going to really push my luck, but I would love 50. So, but to answer your question, yes, if someone has myalgias on statins or whatever, we can make up a whole bunch of stuff and make it look good and we can get it approved, then great. But I will tell you, most patients really, if you can just get them to take it, they don't have issues with their statins. They really don't. And truthfully, CoQ10 really does help with myalgias. The enzyme that kind of statin suppress some. So I always try and convince them, because the insurance is never going to cover it without at least trying the statin first. So we have different medications, right? So it's not just statins, just to your point. So we usually start with statins, and we have our PCSK9 inhibitors. Bempedoic acid is actually pretty cool, and I use it quite a bit. It's kind of like the precursor to statins. Again, it's very expensive. It's not really covered that well. And glycerin. So my old program director, I said, how'd you get that LDL less than 10? I've seen you eat. We go to dinner. How'd you do that? Inclisiran. So inclisiran works genetically like as the precursor to PCSK9, so it like inhibits it from even like being made, the PCSK9. So the problem with inclisiran is inclisiran from an insurance standpoint is not considered a pharmaceutical benefit. It's considered a medical benefit because it's an infusion. And so whereas a statin copay might be $20 or a PCSK9 inhibitor copay might be $100 because you get it at your pharmacy, that has to be done at an infusion center. So the deductibles are like $2,000, $3,000 for the drug. So I try to explain that to the pharmaceutical rep. I'm like, it's not going to work the way you think it's going to work because people aren't going to be willing to pay that, even though it works really well. Again, diabetes management, colchicine we spoke about, and preventive measures. I mean, a lot of the time it's just, dude, you gotta lose weight. We gotta get you unstressed. My worst patients, and I can say this because my husband's a lawyer, my worst stressed patients are the lawyers. They're the worst. Like they're so, especially the litigators, they're super stressed. They've got big bellies. They're just disasters, all of them. So we talk a lot about mental health. I actually have 2 separate lawyers in my practice that are on like disability because of their stress from their job and having heart attacks, 2. I know that because I have to do 15 pages of paperwork every year for them. This is cool. This I actually just threw in today because I forgot to put it in before. So there's a really neat company called Cure Matrix. I am on their medical advisory board, unpaid. I just sit on their medical advisory board. And it's an artificial intelligence company where they will take a mammogram that every woman over the age of 40 has every single year. And that patient can pay on average about $100 if the company like works with whatever hospital they're at. And they will send it to this company called Cure Metrics, and they will evaluate for breast arterial calcification. Because there's a correlation between having calcified breast arteries and calcified coronaries and coronary disease. So a woman can go in for the same test and get the same radiation and the same imaging she would get every year and be able to get a measurement of what likelihood she has of having coronary disease for $100. It's awesome. So a lot of the large hospital systems are starting to implement this. And what I was really happy to hear actually is the American College of Radiology breast radiologist or something, the BIRAD score. So now they have implemented that every radiologist should be commenting on breast arterial calcification on every mammogram to help women then go see a cardiologist and get screened for coronary disease. So this is what it looks like. It lines out in green the breast arterial calcification. Really, 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 really cool. So women with breast arterial calcification are 3 times more likely to experience an adverse outcome. So it's being able to manage risk factors without any additional radiation or any additional testing, maybe just an extra $100. Pretty cool. All right, so take home points. The more information we have, the better. Like I tell my patients, I don't know. I don't have x-ray vision. You don't know unless you look. You gotta look. Communicate and explain to patients the importance of decreasing inflammation. Sometimes, again, visualizing the coronary disease on the CTA is all it takes. So you want to get someone to stop smoking or take their cholesterol medication, all you got to do is show them a big cholesterol goomba sitting in an artery, and guess what? They get it together pretty quick because they can't feel it. So unlike plastics and all my other colleagues that make everyone look so great, they can see it. That's why they want to do it. So when they see this, they tend to change. Don't be afraid of new tests and diagnostic studies. Educate, educate, educate. I probably talk about weight loss more than I talk about coronaries in my practice. Obesity is not healthy, period, end of story. Use tools to help patients visualize and understand. So the first thing with the FFR, all the colors, I actually have access to their portal, so I open it on every patient and show them exactly what everything is. And then again, take the time to explain the benefits of exercise, diet, and pharmacotherapy, and why, the pharmaceutical companies aren't just trying to make money, they're actually trying to help us too. And then 20 years from now, will you wish that you had done something sooner? And that's what I say. I say that a lot. I'm like, listen, don't come back here and say, I wish I would have done what you told me. Because that is a guilt a person never wants to feel. And at least 1 to 2 times a week, I have some patient that came in and had something bad happen to them, and some doctor 10 years ago told them to take something and they didn't take it, and now they feel bad. Like they have a family and they feel guilt, and there's no reason to feel that guilt. Prepare and prevent, don't repair and repent. That's it. Questions? No, there is. There's a lab that measures it, oxidized LDL. You have to measure it by itself, but there is a lab measurement for it. So for me, it's a little different because for me, it's not going to change treatment. Again, because it's like a number on a paper. I will tell you, I get coronary CTAs in probably 80% of my patients. So for me, it's just being able to point at the artery on the picture and show them. Everyone's a little different. I think preventive cardiologists that charge, thousands and thousands of dollars and they go through the lab one by one with their patients, but you have to have a very educated patient for that. So for me, it's really the lipoprotein A. And what I was going to mention, the difference between LDL-C and LDL-P. So if you think of like a cargo truck, the LDL-C is how much cargo is on the truck. The LDL-P is how many trucks you have. So if you have more trucks that can ram into the arterial wall, that's a problem, right? So I look a lot at personally, I look a lot at the LDL-P, the HSCRP, and the plaque. Yeah. Not so much of the particle size. It's really hard to navigate, it's really hard to change particle size. Like, it kind of is what it is. Yeah. Yeah, and the treatment all becomes the same. It's diet, exercise, weight loss, statin. I mean, no matter what you do, it all boils down to the same treatment across the board for all of them. Mm-hmm. Yeah, 'cause she had coronary disease. Yeah. So once someone has that diagnosis, which is like ICD-10 code of I25.10, it's coronary atherosclerosis without symptoms, basically. That's LDL less than 70, right then and there. So so at that point, you want to do all of that. That's very important that she maintains her lifestyle. But now you're truly treating a disease process. You're not treating a risk factor, right? So for her, I'm not really even so much treating her LDL anymore. I'm treating her and her coronaries. It depends on if I feel like a lifestyle modification is going to change, right? So you can usually look at the person and listen to them talk about their lifestyle and know if it's going to change anything, right? So if she's 50 pounds overweight, yeah, I'd probably try lifestyle modifications first before I do anything. But there's a lot of people that they exercise every day, they eat pretty well, and that's the thing too. You have to ask patients, like, I need you to do what's maintainable for you, right? So it's easy for me to say, well, vegan's the best. It is the best. I'm not going to be a vegan. That person's not going to be a vegan. So me telling them the best, that doesn't work. It has to be something that's maintainable for them. That's the most important, probably, to take away from this lecture for everything in your entire career. Whatever you ask someone to do needs to be maintainable for them, and they're just going to fall off the wagon. It's going to be a problem again. So it's kind of, what do you like to eat? What don't you like to eat? So if someone says, like, I love red meat, there's no way I'm going to stop eating it. I live and die by my filet 3 times a week, and I must have a hamburger. Put them on a statin. They've told you that they're not going to change, right? So it's kind of a conversation. But I usually repeat that in about 3 months. So if we do lifestyle intervention, then we repeat the labs in 3 months and see if there's been enough of a change. But ultimately, the LDL needs to be under 100. And it's not easy to push an LDL 40 points. It's very hard, very hard.
As a cardiologist, what would you recommend for people at our age to do to prevent this?
Stress management. I was in med school. It ain't easy. Stress management, exercise. Like, you got to exercise like pretty much daily, even if it's just a brisk walk exercise. And really, like, kind of knowing your numbers, which we teach people. Like, you need to know where your LDL is baseline, right? If you're kind of at your healthiest, you're going to be at 25 years old and your LDL's high, you got a problem. So you can't be really afraid to treat things early, right? This atherosclerotic burden starts in your 20s. If it's going to happen, it's going to start happening in your 20s. So if you treat it now, you can potentially not have that 30% cholesterol plaque at 35. So.
kind of going off of that, where do you start with someone who has like really strong family history, but doing everything right individually? And then also, like, are you doing the lipoprotein little a on every single
Yeah.
person at least once?
So I get a lipoprotein A on every single patient, at least once. Well, they usually need it once. Every single patient gets a lipoprotein A in my patient. And then I take into a little bit of an account age, where they are with their age and what their family history really is, right? So I'll give you an example. If dad dropped dead at 45 years old, but dad smoked 4 packs of cigarettes a day, I don't really know if that's so much of a risk factor at that point, right? So you got to really kind of tease that out. But I am not afraid to order coronary CTAs on young people. I try not to do it on women that are too young because it's still radiation to breast tissue. So you got to keep that in mind. But I usually start scanning men with high risk at 35. And then I'd usually do about every 5 to 10 years based upon what their scans look like. Because it's really not a lot of radiation for the information you're getting.
So even if all their numbers look good, but the family history is bad, still get that at 35?
No, not necessarily. No.
Okay.
No. Because again, I don't know, ask a 30-year-old man, like, well, when you were growing up, what did your parents eat? I don't know. Like, it's hard to tease out where that real risk is. It's there in the lipoprotein A, subtly, it's there. So if I have a 30-something-year-old with that all their numbers look great, questionable family history, and the lipoprotein A is pretty high, then I usually scan them. Yeah. Let me get, yeah.
So are you recommending coronary CT angiograms as a replacement to stress tests or to have done in conjunction with them?
Depends on why someone's doing the stress test. So if a stress test is being done for prevention, unequivocally, I think that's a total waste of time and resources and energy and money and everything. You'd have to have a pretty stenotic lesion for it to show up on a stress test. And then there's a lot of other issues with stress tests like balanced ischemia. There's all kinds of stuff. And I was nuclear boarded for a long time, and yeah. So if I could pick between the two, for sure, and I would say, I'll just give you numbers. I probably order in a year, I don't know, maybe close to 200, 250 coronary CTAs, and I probably order 2 nuclear stress tests. Yeah, so I think they will be totally replaced for the most part. There's a little bit of an issue with stents and artifact with coronary CTAs on very good scanners at very good institutions. They're fine. But if you have kind of like a not very new and a larger slice CTer, they can't really handle stents very well. So it depends on the imaging center too.
What is the current adoption rates of CCTAs around the United States?
I don't know. I think it's city dependent. So your larger hospitals for sure have them. Like we have a level 1 trauma center, they have them. The smaller cities probably don't. They can do calcium scores. And the reason for that is it's kind of a difficult test to do. The heart rate has to be low. So you cannot do a cardiac CT if the heart rate's in the 80s. It's never gonna happen because it's a gated study. And so they can't stop it enough to like look at the images in between beats. So you have to have a center that, number 1, has a good enough machine, number 2, has a tech that knows what they're doing, and number 3, can administer the IV beta blockers when they need to, which is sometimes difficult. I think it's definitely ramping up because I used to order them, like even right out of fellowship, I believed in this and ordered them all the time. And now like all of my colleagues are starting to order them too. Because they really are starting to kind of replace the diagnostic cardiac cath. So if you come to my office and you have a chest pain that's sort of questionable, you get a cardiac CTA. Like we don't even go the stress test route because I'm not going to trust the stress test, right? So if someone says something to me that's really makes me feel icky and I do a stress test and it's normal, it's still not enough for me. Like I need proof that everything's okay. So I think it's getting there. I think it's getting a lot better. Matter of fact, the chest pain guidelines for the ER are now recommending coronary CTAs. That's a new guideline from like 3-4 years ago. So in the emergency setting, it's definitely taken off because they can do triple rule outs in the ER. So they can make sure you don't have a massive PE, an MI, or an aortic dissection all in one study. All right, so then they go home. And so we're admitting a lot less. Like when I did hospital calls still, someone came in with chest pain and their heart rate was 60 and they would call me for a chest pain admission. I go, no. Cardiac CTA, call me back. And they hang up the phone. CTA was normal. I go, exactly. See, we just saved an admission. They get to go home. Yeah.
How much of your work is insurance versus cash? I know you said like the $500 testing and then like the AI thing that's looking at like the plaque composition. Is that just included in the scan or is that an additional thing? If you could talk a little bit about that.
So in my practice, for my services, I'm all cash, except Medicare. Medicare I take. But we're able to get these tests authorized by insurance company about 80% of the time because they have symptoms, or maybe they'll have an abnormal EKG that I know is not really abnormal, but like the insurance company doesn't know that. You know, they have an incomplete right bundle branch block that nobody cares about, but I use that as a way to get it covered. So we're pretty good on coverage, but most patients say for $500, I'll pay the money and get the test because most of them haven't even met a deductible anyways. So if they have to meet a deductible, this is $500 and a nuclear stress test is $1,500. That gives a third of the information. So, and then no, the AI is not. The company is the plaque analysis. The company is working on getting insurances on board with that, but most patients pay out of pocket for it. The FFR is covered. So if someone has what appears to be an obstructive lesion, it then gets, the patient's already home. The radiologist at our institution, they don't even have to call the cardiologist. If they think it's obstructive, they send it off for insurance verification, which they usually get in an hour, and then they send it off for a CT FFR. We have the results back in 2 hours. Yeah. So at our institution, if there's something that it even appears obstructive, her cutoff is 50%. 50% or more automatically goes for CT FFR. Yeah. Anyone else? Yeah.
So how often are you recommending like patients that you're putting on statins to take the CoQ10 that you mentioned, and in what dosing?
So it depends on if they're having symptoms. So if they're younger and they're not having any symptoms, then I don't think they need it. Most older patients, I recommend it period because it usually depletes as people get older anyway, and then you're putting the statin on top of it. Any patient that has myalgias, I recommend across the board. It comes in different doses. It's usually about 200 milligrams a day. But I will tell you, I have had a lot of success with it. Like I had another doctor actually stop me in the hospital one time and say, I took that CoQ10 I saw you talking about on TV and it really worked. So yeah, it does. And it's definitely not going to harm anything. And that's the thing with supplements, right? We're not harming and it might help. And then I tell them, if it doesn't help, stop taking it. Give it 2 weeks. And if it's not helping, then stop taking it. But it really does help a lot of people. Yeah.
Do you have any other supplements that you use or?
I'm generally not a crazy supplement person. So if I had to pick a multivitamin, omega-3, CoQ10 if they're on a statin, and if they have palpitations, magnesium. Because magnesium really does help the palpitations. It'll suppress PACs and PVCs to the point where they're not as symptomatic. Yeah. So those are my big four. And then obviously you pick based upon what's going on with someone, right? Sometimes there's supplements that are very good for certain people, but as a general rule of thumb, those are my top four. Anyone else?
Yeah, how did you get into preventive cardiology? Haven't heard too much about it personally, so.
I don't know. I think when I was in fellowship, I kind of got sick of seeing sick people. And I don't mean that in a bad way, but I'm like, all of this could have been prevented if someone just would have figured it out earlier, right? So that's kind of what it was for me. I got frustrated with people just either waiting too long to get treatment, or they just weren't educated, or someone didn't take the time to educate them, or didn't have the time to educate them. I don't know. And I like the physiology behind the whole thing. And you really can change someone's life. You truly can. Like, I actually had a patient that had plaque regression. Like, he had a 30% non-calcified plaque on his coronary CTA, put him on 40 milligrams of rosuvastatin. LDL went to 40. I rescanned him in 5 years. It was gone. Nothing else is going to do that, right? But had he not known about that, it would not have been gone, right? He only started treatment because of that scan. So for me, that's what it was. I like being able to sit in my office and pull up labs and go through things one by one with people and prevent them from ever needing to have their chest cracked open. It's pretty uncomfortable. No.
Did you go right out of fellowship right into concierge medicine,
Yeah.
or did you start? So what's that kind of pathway like?
Dr. Hasty will tell you I'm probably not someone that should be employed. Yeah. I have way too many opinions to be employed. But I started out with a hybrid model. So I actually, when I was in fellowship, I opened up my practice and I just worked on the weekends and after hours with my husband at the time because he was out. So it started as just doing medicine, and then when I got out and as a cardiologist, I dabbled and put cardiology into the practice. But for concierge, it started hybrid. So I started by saying, oh, you want to be concierge? This is how much it is, but I'll still see these people with Blue Cross Blue Shield. And it got to just be too much. And I had to just pull the trigger one day and say, I'm only doing concierge. So I've been doing that now for, I don't know, it's probably been 10 years now it has been 10 years now that I've been concierge only. And then about 4 years ago, I actually dropped all insurances too. So it's my concierge is just the annual fee, and then it kind of covers everything we do in the office. And then the cardiology is cash and Medicare, but most is just cash. They pay, they come in, they get their labs, and they get an echo and a carotid ultrasound and whatever else they need that's done in the office. And they get comprehensive summaries after their visits and things like that. Yeah, I was allowed to. Yeah. Yeah. I had a great program director that really let each fellow excel in what they liked. So when I tell you we had to do 100 cardiac caths, when I tell you I was at 100, I was like, see ya. I was out because I knew I never wanted to be in the cath lab again. And he was okay with it because I had to get my 100 to graduate. But he knew I really liked lipidology and he knew I really liked prevention. So he let me kind of explore that. So I was kind of blessed in that sense. I wanted nothing to do with EP. I didn't want to smell the EP lab. I wanted nothing to do with it. And he's like, listen, just meet your COCATS criteria and get out of here. So, yeah.
In med school, is it something along the lines of when you saw yourself, or?
I don't know. I was kind of on the fence with ER in med school at one point because I just kind of liked the idea of working and going home. But I also kind of didn't want to, when I started thinking, I didn't want to kind of like a cap in my salary. You can't work every day, all day. When you own your own business, you can kind of figure that out for yourself. And then when I was in internal medicine, I was like, I cannot round in a hospital all day long. There's no way I can do that. I just knew my personality. So I got into cardiology and kind of figured out I wanted, and as a female cardiologist, very few female cardiologists. So it was kind of, I don't know how to say this nicely, but I kind of knew I was going to be successful because there's not a lot of us. So women tend to want to see women doctors, generally speaking. So I was like, well, I literally opened the door and it was just a flood of patients then because there's only 2 other female cardiologists in a 10-mile radius of my office. And they had all been in practice for, 15 years. So. Yeah. Thank you, guys.